Hello to our colleagues joining us from all across the world. On behalf of the IFAC Academy, I am Praveen Chopra, and as chair of the Academy's Scientific Advisory Committee, it is my privilege to welcome all of you to another episode of Conversations with the Academy, which is an initiative under the umbrella of the Academy's value-added programs. These offerings aspire to elevate the professional ethos, strengthening the sense of community, and address the academic needs of our members, exploring trending issues affecting evolving healthcare scenarios. And with the burgeoning challenge globally today with healthcare costs and access, value demonstration becomes imperative. And today's session on health economics and outcomes research seeks to examine just this. To drive this important issue, we are indeed dignified with the preeminent faculty sharing their insights and expertise with us today. Please allow me to introduce, and Kit, may I have the next slide, please? Please allow me to introduce Laurent Pacheco, chairing today's deliberations. Laurent brings a formidable combination of good science and good business, having trained both as a physician and in economics, with a master's in pharmacology to boot, along with health systems administration and business administration from the prestigious Essex Business School. In his current role as managing director at Syneos Health Consulting, building upon his earlier leadership consulting ventures at prominent organizations, Laurent has been instrumental in establishing and driving pharmacoeconomic access and pricing strategies in the biopharmaceutical space. Thank you, Laurent, for introducing our panelists today and the aspirations for today's critical conversation.
Thank you, Praveen. Good morning, good afternoon, good evening, everybody, wherever you are. I'm very pleased to be here today with our panelists. Before I introduce Seema and Jennifer, a few introductory comments. The first thing, this is an important milestone for us because this is the first time we run this webinar specifically. You know, these initiatives from IFAP have run for a number of years, but this topic is the first time. And also we are taking a bit of a different approach to it. It's not a lecture, as Praveen mentioned already, it is more a discussion, right? So hopefully quite live as well with you. We will be sharing this hour together. You may interact with us. We invite you to via the question window. So on your webinar system, you should see on the right a number of options. One is questions. So if you click, this would open a box, and please share with us so we can comment throughout. At the same time, we already have a few questions from you that you shared when enrolling for the webinar, and that we have included in our discussion today. In addition to this, in the system, we'll offer polls. So we'll have 4 themes today. And for each, we'll introduce our discussion with a poll that you see on the screen for you to vote. And based on that, we'll share thoughts with you. So now on the next slide, let me introduce you to our panelists. We have Seema Haider, who brings 25 years experience. She's led international and multidisciplinary teams and developed and executed strategies in HEOR, real-world evidence, and also value and access plans. She's published quite a number of papers in well-known journals. She owns a master's degree in social and preventive medicine from the University of Montreal, where she also completed a PhD. She specialized for a PhD in pharmacoeconomics and was later on a project director in the health economic unit. From the business side, the pharma side, Seema was country manager, specifically for pharmacoeconomics and quality of life research at Sherinplo in Canada. And later on, she spent 20 years with Pfizer, lately as cluster head for HEOR. And still in academia, she's also a visiting professor with Hebei University in China and a member of our faculty for the IFAP Academy. Thank you, Seema. Very pleased to have you today with us. And we also have Jennifer on the next slide. Jennifer Stephens, who is a partner and clinical director with Pharmerit in the US. Jennifer brings 20 years of clinical experience. Before her role with Pharmerit, she was with Parexel, where she managed the outcomes research group, and also she worked with the ADC associated clinical trials. As a HCP, a pharmacy, she has very much hands-on experience in market assessment, health, economics, and reimbursement. She's developed numbers of dossiers, economic models, run prospective and retrospective observational studies. Jennifer is also board certified in pharmacotherapy and has extensive patient care, again, as a registered pharmacist. She received a PharmD degree from the University of South Carolina, and later on pursued her residency with a focus on outcomes research at the University of Maryland. A very strong panel today. I'm very pleased to welcome you, ladies. And I'd like us to start. I'll introduce the key streams on the next slide that we'd like to cover today, the key topics, which are cross-functional collaboration in pharma, with, of course, today a focus on medical affairs and HEOR, patient centricity and real-world data, and the digital transformation and its role in communication. So to dive a bit deeper on the next slide, I'll give you more of a taster again. We'll discuss this evolving healthcare landscape that for sure we all know, right, but this very much shapes our discussions, and this need to demonstrate value always further, how medical affairs and health economics outcome research teams should interact, which could be quite early, and how to team up, the role of the patient perspective, how to generate real-world data. With regards to digital, we'll discuss how this can support effective communication and the role of digital in drug development. And finally, looking to the future, so hopefully some interesting questions or comments from the audience as well. Where is HEOR going with regards to the role of medical affairs? Let's please kick off on the next slide with our first theme on changing landscape and the increasing need to demonstrate value on the next slide. So here is our first poll. We'd like to ask you, what is, you think, most contributing to the increasing need to demonstrate value? So you have 3 items. Our operations team can launch the poll. Thank you. You should see on the screen. So please vote. Obviously, I'm sure a number of you are thinking, well, everything is important. We kind of agree. But please make a choice and we can comment. Yes, very nice. Well, unsurprisingly, it's a quite balanced feedback. Most of you chose growing population and increased spending on healthcare. So maybe we can start with this one, this pressure on public spend. So I'll push the ball to Seema and Jenny. How could you comment on this? What is your experience and how this shape the need to demonstrate value, please?
So in terms of public funding?
Yes, the increased spending on healthcare.
Yeah, I mean, you know, there's definitely new medicines that are coming onto the market, and these medicines are more expensive than we're historically used to. And so what's happening is that there's more pressure being put to support these medicines, to provide funding for them. So it's playing a big role on demonstrating value, because you're asking for more money to fund these new medications, and then you have other ones that are already on the market, so you have to choose where you're going to put your money. And because of that, there's a need to demonstrate, you know, what are you getting for your money, basically.
Yeah, I agree, and I think that HTA organizations are also contributing to this need to demonstrate value because of the increased spending. So you know, certainly there's pressure there to ensure that we are getting good value for money.
Mm-hmm. Yes, I agree as well, and I would say all these three items are linked. There is pressure on healthcare spends, and patient or the public wants to understand there is increased needs for transparency, and they ask why has society spent on this product and not the other one. So actually, there's also a need for decision maker to justify decisions, demonstrate value, and this has led to a number of quite technical methodologies, so that objectively we can explain why this was the right choice to make. Very good. We can move on to the next slide, which gives some more context, and the other answers proposed here can also be discussed. On this, I'd like to ask you specifically, Seema and Jennifer, the role of the patient voice. How do you see it has evolved, and what role it has?
Yeah, so in terms of patient voice, what's happening, there's a couple of things happening, and I think especially the increase in the use of technology and the availability of information through, let's say, sites like WebMD. So you have more access to information, and what's happening is that the patient is becoming more and more informed. So as you become more and more informed, you want to have more input in your care. So you have these two things sort of coming together and creating an opportunity for the patient to have a bigger voice in their treatment decisions.
Yeah, and I think it shows that there's a need for transparency in the decision making, and patients are having a big role in that as well.
Thank you. We have a question from the audience that came to us before the session via email. Someone asked what we find is the biggest challenge in developing HEOR data with regards to emerging markets in particular.
Yeah.
Go ahead, Seema.
One of the biggest challenge in the emerging markets is developing capabilities. So in order for you to develop or understand and interpret HEOR data, you really have to be aware of what it is, what the definitions are, what the methodology is. Emerging markets has lagged behind in this. So there's a big need to train, to educate in the emerging markets, your providers, your patients, and your decision makers.
Yeah, and I think in emerging markets, it also comes down to affordability. So even if we're able to do a cost effectiveness analysis and show that there's good value for the money invested, it may come down to a budget impact constraint. There's just not funding available, even though the new product may be good value for money.
This reminds me also of an experience on projects where, as a service provider, as a consultant, I work with the kind of pharma, and we partner with the Emirates, a number of countries, to discuss with them what is value from their perspective, right? It's also quite culturally defined, and how this should translate in developing a value-based assessment, some sort of HTA framework, if you like, so they could move from an historical, more negotiation, not to say like bargaining approach of procuring products, but adopt this HTA thinking. So the link is that we need to understand what the systems value, what framework they have, but also from a pharma side, we may have a role in helping and shaping the way system would assess.
Yeah.
Very good. I'm checking the question box. It doesn't seem we have yes, we have a question here. A colleague asks how difficult it is to conduct HEOR studies in out-of-pocket markets. So I may actually tackle that one to start. In out-of-pocket markets, oftentimes actually you don't even have such a developed HTA system. Sometimes you don't have, obviously, coverage. So the question is, for pharma, how do we explore these markets? And it's actually more in terms of like value, yes, but also pricing and affordability. So what we do, because in pharma, we can't in these markets speak to a national decision maker and ask for their opinion or their approach to our new drug, we need to go down to patients themselves. And the types of research or analysis pharma run is, for example, patient affordability. So you would need to test with a quite large number of patients. I say large number because you don't have one decision maker. So for your result to be robust enough, the sample should be quite large. And you would test maybe with an online survey, where possible, a number of scenarios to check whether the patient would be okay to pay that amount of money for this product if it's priced at this level. But you also need to know that this depends on the overall income the patient may have, what are the things they would have to pay for, education for their family, transportation, everything, because they have to allocate themselves their own personal budgets. So the thinking there is very different. It's on the patient side. And again, every patient is different. So hence we need a quite large number of participants to these studies. So this informs both in terms of what patients value, because this drives their willingness to buy, right? And at the same time, what affordability the population have, what they can pay. And interestingly, physicians in these markets are also sensitive to patients' behavior, because physicians know patients would pay. So physicians' prescriptions patterns are actually impacted by patients' behaviors.
Yeah.
Yeah.
I think you're still. Go ahead, Jennifer.
I was going to say we've done some interesting studies where they're like hybrid type chart reviews. So we're looking in the patient record, but we're doing patient survey and physician survey to triangulate between the three pieces of information to answer exactly some of those questions. You know, what's driving the patient behavior and what's the physician perception of that? It's very interesting.
Yeah, and I think, you know, in addition to that, we've also looked into how are physicians in these markets managing their patients, and is there any gaps and needs there that we can work on to help in terms of, you know, raising disease awareness, or is as a particular disease a taboo in a market? So all of those things. So really the focus is on the physician and on the patient, Laurent, as you mentioned, instead of the traditional pair that we're used to.
Mm-hmm. Yeah. We also received a question up front via email, which fits here nicely, I think. Someone asked, why are the generic prices lower? It's interesting because we know, right, we take it as a given, a generic is cheaper, but actually, why is that? So say, I am the payer, you are the pharma company, and you are pushing to me your new product, which happens to be a generic. So I would see that and say, well, this is the same as what I already pay for, right? So why would I, payer, want to pay more for something which is the same as what I already pay for, again? So the only way for generics to make their way is for them to tell me, to make me understand, if I can't make any health benefit because it's the same from a clinical perspective, the benefit I could see might be economic. And so then this is the only dimension that you pharma are left to convince me that this is a good deal for me. So you would just like lower your price. And this is what happens. And also I, payer, have a good argument, which is on top of that, I know it hasn't costed you so much to develop.
Yeah.
So prices are pushed down. I suggest we move on to the second topic. I'm checking we don't have any more questions. No, we don't. So on the next slide, we can expand and discuss the relationship between medical affairs and HEOR. And here the poll asks you, what is the most important element to ensure effective teaming and planning between medical affairs and HEOR? So you should see again on your screen the poll exercise with 3 items. Maybe you'll find again all of them are relevant and you can comment on that. What do you find is most critical? Thank you. Very interesting. So you mentioned align on gaps, needs, and challenges as the most important element for effective collaboration between the teams. Seema and Jennifer, any experience to share here?
Well, I agree that that's the best step, initially to align on gaps. But then I also think the second part is to collaborate early, so there's time to address the gaps. I think that's the biggest challenge we face is, not having enough time to develop all the pieces that are needed for launch for HTA submissions. And yeah, to me, that's the biggest, those two are linked really.
Seema?
Yeah, and I agree with that, but I think, understanding the value of HEOR evidence generation or being able to interpret HEOR data is also important. So maybe teaming early to understand, being on the same page, making sure that the team is educated around these, around these methodologies is also quite important, so that we can move forward to align on the gaps and needs and identify, who the stakeholders are and what data is actually needed to support value messaging.
This is a very interesting point. As we see medical affairs taking a much more critical role in pharma organizations, right? We are facing so many different discussions, different perspectives, sometimes technical. So there is a need in terms of aligning on gaps, which is also understanding what concepts the other team uses, which means to which extent should medical affairs professionals be savvy in pharmacoeconomic analysis? Well, maybe a bit to understand, but there should be a limit to that. And at the same time, medical affairs professional basically own patient voice and HCP's voice, and this is quite a different story. But we do need to work together. And one output, I would say, from both these perspectives is the increasing use of PROs, right? Which is how to ensure we bring in the patient perspective, which very much medical affairs professional own again and value, and how do we make sense of it in a quite objective, maybe technical way that works for a pharmacoeconomic analysis, and this links with the other teams. So we see a concrete example where at this interface there might be gaps up front because we may not come from the same universe, don't use the same tools, and eventually this has led to development of very well useful and validated tools in the case of PROs. Let's move on to the next slide so we can expand further on partnering throughout the life cycle management. One question for you, panelists. We hear it's never too early, right? But it sounds a bit of an easy one. So is there a case where it's actually too early, or would you very much advocate and say it's never too early to partner internally?
Yeah, so, the earlier you start, the more prepared you'll be, to collaborate and so on. So in the early period, you can use that time to test your instruments, to work together, to identify KOLs, and to work on a common strategy together. So I think, starting around phase 2 is, it's early, but I think it's a perfect time to start. It also gives you time, as I mentioned before, to train colleagues, and then to work together to sort of develop an HEOR and real-world evidence plan alongside the clinical development plan. So as you're developing the clinical development plan, you can also work on this HEOR, parallel HEOR plan that adds value to the clinical development plan.
Yeah, and I think we have to also work backwards and think about the time it takes to do the different types of projects that you will need at launch. So economic modeling can start in phase 2, really, to inform what endpoints are going to be most useful in phase 3. I think you can start all of these HEOR projects early, and it informs your phase 3 plan. It's pretty important.
Yes, I'm thinking of a case. What is important for HTA is, we've discussed that, the economic dimension, And the economic value can be also justified by savings. Yes, the new drug might be more expensive, but it may also save money from the healthcare system perspective because patients are managed differently. For example, before it was an inpatient situation, and thanks to this new product, it can be outpatient, much cheaper. And that is very strong argument, economic, but pretty strong. And it would support also your price negotiation. But the thing is, for you to be able to provide this evidence, to convince me again as a payer, I'd like to see that. I'd like to see figures. And the way for you to document that, yes, it's cheaper, you'll have to measure it. And that takes time, and it has to be measured in some sort of like a very concrete operational way, alongside the clinical trial, ideally, because anyway, the product is not launched, right? So it can only be in the clinical trial fashion. And as Jennifer said, what we will do for this item specifically, we will need to measure the number of hours a nurse spends with the patient. So we are able to say, you see, it's lighter. There are fewer hours needed there. So there is a saving there. Or as I said, comparing the cost of hospitalization, which we may avoid, compared to the cost of an outpatient visit, which is much cheaper. That works if you are very much, again, able to document, to observe, to collect data, and this can't be developed 2 days before your dossier. It's very much a parallel stream, parallel with the classical clinical trial operations. Okay. I'm checking the question box. I don't think I have. If I'm missing one, please, Praveen, let me know, but I think we don't have it. So let me come back to the ones you shared with us.
There are 2 questions, Laurent. If you look at the question box. Yeah, there's one from Marta. You want me to read it out, or?
Please, yes, please.
So the 2 questions that have come up here, one is Marta's asking a question. This is one from 1 second, let me just pull up the 4. So first, Danielle is asking a question which is relating to pricing is another part of the HEOR question and is arbitrarily set by pharma. How can medical affairs build trust in the pricing process of pharma to demonstrate our commitment to access, in addition to innovation and business sustainability?
I think this is where economic modeling comes in and is so important to demonstrate that the price selected, there's actually good cost benefit, or there's downstream cost savings. So I think economic modeling is important here. And this is where I think medical affairs really needs to partner with HEOR so that the right methods are used, the right approach.
I think, I mean, I'd like to come back to the example of emerging markets, but one out of many other situations, right? But as we said earlier, the patient behavior and physicians' willingness to prescribe, being price sensitive, this is a bit unusual for us maybe in developed markets, but over there in some markets where maybe you audience are, physicians are very aware of the cost burden to patients, and they adjust their prescription based on that. So this means that this very medical attribute, the value, the behavior, physician behavior is very important in the equation, in the economic equation, and of course in the pricing equation, because we understand that the higher the price, the less likely the physician will be prescribing, knowing it's such an impact on the patient's out-of-pocket payments. So that is a quite clear example where medical understanding of the real patient care, how things actually happen between patients and physicians, is critical.
Yeah, and you know what? I think that from a team perspective, for medical affairs to build trust in the pricing process, you really have to have good cross-functional collaboration. And as we've been saying early on, so everybody understands, the disease, what the competitors are, and all of that. So I think raising that awareness, being involved, medical affairs being involved as part of teams where price is being talked about is really important as well.
Yeah, and I also think that this new emphasis on the patient voice being included, this is important to be thinking about early as well, because it takes so long to do those studies. I know, a lot of the cancer therapies, over the past few years, maybe they skip adding PROs to the clinical trials, but that really catches up with the teams when they're trying to do their HTA submission. So we've had examples in both in Canada and UK where they've come back and asked for the patient voice. There's no PRO data collected as part of the trial, so the companies are going back and trying to find ways to show patient impact without having PRO data. So they'll use things like the adverse events collected in the trial to do a Q-twist, or they'll have to do a subsequent study to look at patient voice, do a patient journey study, interview patient groups. And sometimes those then can be accepted as evidence that there is value for a new therapy. And so this is particularly important, I think, for cancer therapies, rare disease therapies. And there's going to be a trend where this is taken care of in between phase 2 and phase 3, and not waiting until the product's ready to launch, because it does delay the HTA approvals.
Thank you, Jennifer. We have a comment from Sam, who mentions that it all depends what healthcare system and in what jurisdiction. And of course, we've mentioned emerging markets. We've just discussed Canada, and one very first approach is to understand your market, your payers, what methodologies they use, what value framework are in place. This very much depends. Sometimes pharmacoeconomic, like in the UK, would be almost the sole, or at least a key decision metric. In some other countries like Germany, not at all, would be budget impact. And of course, emerging markets, again, different story where you don't even have a system in place. So yeah, thanks, Sam, for making clear. It all depends, and we need to know our stakeholders, our markets. Shall we move on to our theme number 3? I can see the questions, by the way, now. Thanks, Pravin. And our theme is generating and communicating stakeholder data. We ask you here in this third poll, which is the most critical strategy to ensure effective communication to stakeholders? Tailor messages, involve internal and external stakeholders early on, or maximize the use of multi-channel. What do you find is the most critical approach? Involving stakeholders. So we've somehow covered a bit internal stakeholders, at least as we discussed medical affairs and HEOR in particular early on. Now external stakeholders, that might be a different story. Seema and Jennifer, what experience would you like to share in terms of involving external stakeholders early, please?
I think we typically see the best approach is really to bring the external stakeholders in early, but between phase 2 and phase 3, so that their input can really be understood. And by external stakeholders, I'm thinking of physicians, patients, even health economic experts, to really drive what's going to happen then in phase 3. And I think it's interesting. To me, like maybe tailoring the messages to each stakeholder is probably the key thing. But to do that, you have to involve the stakeholders early, and then to communicate it, then you have to use multi-channel to communicate effectively. So again, I think these are all linked.
Mm-hmm. I'll add to that that in the same way as you're probably used to the regulatory agencies offering scientific advice early on, HTA bodies, which today are our main external stakeholder, also offer They call this early consultations, but it's kind of the same idea where you can request a discussion with them. So you discuss your clinical, but also pharmacoeconomic data plan to be sure you will be meeting their expectations, and they give you feedback. The tricky part is that each country would have their HTA body and can run their early consultation. You may request a few of them at the roundtable at the same time, but they're not requested to align, and so they may diverge in their comments, so that may not help you so much, for example, in terms of how to design the trial in the way that pleases everybody. It's not always the case. Typically, the point around what is the relevant comparator for one country may not be the same as in another country. Still, it's always good to hear, and they would provide advice. Another specific case, how to handle indirect treatment comparisons if you are in a situation where this country doesn't have on their market, the product you've used as a comparator for other countries. Well, you're lacking data there, right? And you should discuss with them what type of indirect treatment comparisons they could receive to make up for this gap. Another way, of course, to interact with the external stakeholders early is some sort of research. So in market access, pricing, or HTA strategy, we run a lot of research which look like the patient or physician research you may have in medical affairs. But in our side, HEOR side, is very much testing scenarios, product scenarios, price scenarios, access scenarios with these decision makers early on to inform, for them to give you their view and to inform your strategy. I'm checking the comments again. We had a comment on digital, and I think you mentioned that already, our panelists. How do you think is going to impact the digital area in the management of patients and costs? So we have a colleague here, Marta, who asks how digital is going to support patient management and inform costs, I guess, cost of treatment. Would you have a view, panelists?
Yeah, well, I mean, I think there's going to be an increased emphasis on digital therapeutics, so helping the patient monitor their disease, their outcomes. So certainly that's certain to be a trend.
You know, I think the pandemic has really helped us in this realm. The fact that we're seeing our doctors, you know, through the web on video calls is you know, it sort of pushed all of these things up front. So I think more interaction over the web is going to be a way to manage patients in the future. You don't necessarily have to go to the offices, and also, you know, with all these applications where they can monitor your heart rate, or you can check your blood glucose and then send that information directly to your physician through the internet. I think all of these will impact the way patients are managed using technology.
We can move to the next slide, Kit, please. Yes, indeed, digital, like everywhere, right, is finding its way in all phases, in all dimensions. Another example is the use of smartphones with specific apps alongside clinical trials, where we actually want patients to document their experience, their intake of the drug, their symptoms, what pathway they have in the healthcare system. So of course, it's all pre-designed specifically for the product, for this trial, with a digital agency partner. And so patients will tell you, well, they pain the experience when they take the pill, when they've seen the nurse. So that, of course, you should have this information the other side as well from the healthcare management group, and you can reconcile. But it gives you a number of very important elements around what patients experience. health status. So this informs the patient-reported outcomes, but at the same time, it documents via the patient pathway resource use from the patient perspective when they see the doctor, when they go home, when they come back for a visit, if they stay 2-3 days. And that, as we mentioned earlier, you can then turn into cost elements when you know the unit cost for each of these activities. So we see here digital just being ingrained in our day-to-day tools. Very much fits in the routine of clinical trials, and at the same time is able to document almost a 360-degree environment, symptoms, experience, pathway, physically, resource use, and that you can match also with the more classical databases, data sources you have.
Yeah, and I think, in the real world, right, when your patients are in the real world taking the medication, I think digital is going to start to play a greater role in checking adherence, because we've always had trouble with adherence for, let's say, antibiotics and, other medication where patients kind of drop off and stop taking their medication. And one way to put a check is through, the digital medium, through sending patients reminders, like we get now phone calls from CVS or, our pharmacy, that your prescription's about to run out, come and get your prescription. So that sort of thing.
Yes, and you mentioned real world, actually makes me think we also received this question up front last week. And this links with our fourth green stakeholder on the screen, payer HTA. Sometimes they find clinical trial data is not enough. They want to see real world evidence. So how do we collect real-world evidence when we are just finishing our clinical trials? Payers want to see them, and we don't have them yet.
Well, I think there's for many payers now, they do have access to data, so they're doing provisional approvals. So they may approve the therapy for use, but they're immediately following the data in the health plan or in the country for patient outcomes and cost impact. So provisional approvals is one approach.
Yes, there may be cases where your product arrives at an agency, is on their table, but maybe it's launched elsewhere. And so in this case, well, that's, I guess, an easy answer, where you can document for this country what you observed in this early experience with in other countries. Of course, another point also is to document as much experience that you can have in real settings with other products. So obviously it's not so specific, but if you're not first to market, first in line, I mean, you can extrapolate what your product might bring in regards to what is the actual real life experience with comparable product, if not fully similar. And finally, as well, along the clinical trial, if you can anticipate what could be a routine use of the product, we know it will differ for sure, right? Real life is not clinical trials, but sometimes we can also test and model and approximate early on. So it makes your data closer to real life, even if it's not full real life yet, and that helps your discussion with payers.
Yeah, and you can always go in and look at real world practices of managing that particular disease, right? So it's not always about the product, it's also about how you're managing the disease, what is being used to manage the disease, the price of that, and then you can sort of put in placeholders, or by the time you're ready to present to these types of stakeholders, you have an idea of what it's going to be. You can use a range, for instance, for some of these values. So there's different ways of doing it.
I'm jumping on a question here from a colleague who asks, in a value-based approach, do you think that we need to also consider societal value, for example, family-reported outcomes?
Yeah, I think so. Certainly for things that are affecting children, because if the parents can't work, it even places an even greater burden on the family and the ability to afford care. So certainly, and often I think those are the outcomes that are the first to get cut when you're designing the ideal clinical trial plan, and what patient-reported or caregiver-reported outcomes are going to be included. Those types of things are the first to be cut, but I think they're so important to leave in. They have a big impact downstream that you actually have the data instead of waiting.
Yeah, data is very important on this broader societal perspective. But the other very important thing is like know your stakeholder. It's basic, but this is why also you want to research and interact with them upfront. You want to check whether they would value this data. And the sad truth is sometimes they just won't. Because it's not their framework, is not planned for it. I'm thinking Germany has a very structured HTA framework. It's all like by law, which is great because it's super visible. It's great for transparency and you know how to navigate that. But the thing it means, if it's not planned by law, it's quite unlikely that it will be valued, right? And other countries, for example, the Nordics, are known to consider a broader societal perspective. We have here a discussion around family outcomes, but for example, even the loss of productivity because you are sick, obviously you can't go to work, or even the mother looking after her sick children, she may not be able to go to work, and this is considered a loss of productivity for society. And some Nordic countries actually value that, and they take into account the impact it has on the economy, meaning if your product is able to cure patients faster, this solves this economic impact on loss of productivity. And this is very much a societal perspective. That works, and you have an argument if, like the Nordics, all your stakeholders are sensitive to that. Sometimes they wouldn't, and they will tell you, well, good to know, but this is not part of our equation, not part of our decision-making thinking.
Yeah, and Laurent, I'd like to comment. I think it's important what you've brought up, and I think historically what we've seen as this discipline and as our stakeholders have become more seasoned, more educated, we've seen that at the beginning, like let's say in the mid 90s, there was a lot of focus on societal perspective, but then as we became practical and we started bringing in these evaluations, you saw a movement away from the societal perspective. But I think that things like caregiver burden or family outcomes, as we've heard today, I think like Jennifer said, they are important because caregivers are important. You do have losses of productivity, losses of time, and also they impact your quality of life. So all of these things are important.
Very good. Thank you, Seema. Thank you to the audience for the questions. Let's move on to our fourth and last theme today, looking to the future. We can go to the next slide, please. HEOR for market access, and a poll again for you, the last one. We should have the poll number 4 here, which asks, what is the future of the HEOR medical affairs relationship? Which would come as a different question. Yes, thank you. So you have 3 items. Again, looking forward, what you think would be critical? Earlier collaboration, more integration and joint initiatives, or an improved understanding of value and the basic HEOR tools? Good, let's have a look at the results, please. The green bar is very popular today, I can observe. More integration and joint initiatives, that we've commented already. So indeed, it is important, and I see the audience see this growing in the future. So Seema and Jennifer, what joint initiatives could we think of? How is this going to grow in the future?
I was going to say, I think there's probably going to be more emphasis on joint initiatives around digital presentation of data, of HEOR data. You know, I can think of trends that we're seeing in our types of projects where you know, data dashboards are being used to present large amounts of data from, for example, chart reviews in multiple countries. And being able to drill down so that the physician can actually benchmark where they are compared to other countries. I think that's very important. But we're also using data dashboards for large systematic reviews or lit reviews and meta-analyses. So, you know, we're hearing from a number of companies, and this has been a trend over the last 3 or 4 years, that they're really going to focus on digital. And it's only been accelerated now with COVID. So, you know, we're hearing from several companies that 2021 is their year of digital, but I know this has been happening in other companies for the past 3 to 4 years. So I think the joint initiatives around digital presentation of HEOR data is going to be a key trend.
Maybe we can comment further on the next slide. Yeah. So I also think this was, I think, the third option in this poll, where we discussed better understand the tools and the concepts. Of course, integration is already happening and going to grow, but for that, we of course need to understand each other. And I observe in my project that we have more and more often requests from medical affairs teams who ask us to educate, to train, or to run a number of workshops on what is pharmacoeconomics, for example, what is HTA, because as you can see on the slide, and this comes from a McKinsey report, medical affairs is more and more strategic, as we said also in the introduction, and as such, well, it's great to expand the scope, this responsibility, and the number of interfaces medical affairs have with other professionals, but again, need to understand also what they do and how they work. And as such, understanding the others' tools. Of course, we don't need to become experts in everything. It's not our mandate and not possible anyway, but a bit more savvy, aware of how others operate. That should be probably the first step before really pushing this the joint initiatives and collaboration further. Seema, you mentioned you had a comment.
Yeah, I was just going to say, you know, Jennifer talked about on one spectrum about the communication, coming together to communicate. But I think before that, you know, while we're working to get there, I think there's going to be more and more joint meetings with medical affairs. I think we're going to be on there, you know, from a practical point of view, HEOR will sit on the medical affairs LT. This, you know, in my experience, this had already started to happen at Pfizer. And then working together on a strategy that's aligned and combined, really. Being, you know, when we were doing, I'll give you an example, when we were doing studies, what the core study team, the very basic study team, would be the HEOR person or the HEOR clinician, as we call them, and then you know, a biostatistician, and then we also had an individual from medical affairs who was the clinician or the clinical expert on this triad. We called it the triad, and this was the core team that was involved in all studies and all publications and so on. So we saw, you know, a greater integration between HEOR and medical affairs in this way.
I'm going back to our questions that came from the group before this webinar last week. A colleague asked, how can HEOR meet sustainable development goals? And I find this is a very interesting way for us to look forward and maybe conclude. We're close to the end. So these sustainable development goals, as you know, are initiated and strongly supported by the UN with the view to support global health and well-being. And so how can we, pharma, I guess broadly, and specifically with our HEOR tools, align and support this view? And I find, in a sense, HEOR is here to help, of course, demonstrate value, but somehow this also contributes to try and solve this equation, which is where we need to fund pharma for a sufficient return on investment to sustain R&D. But then we also have a public spending pressure. It costs a lot, and there is a limit to what society can pay for. So there is a first tension here. And finally, we want patients to have access, and ideally, equal access, unlimited access. So we have a volume issue as well. And so this is our three-dimensional equation. And I find the world in pharma we all work in is to help make this work, fund R&D, ensure this is sustainable from a cost to society perspective, and patients have a broad access. And I think in this way, we are, aligned with these sustainable development goals, where this eventually would support good health in a population manner, right? There's always choice to be made, but I guess from a broader perspective, a population perspective, HEOR, medical affairs, and pharma, broadly speaking, very much supports this SDG vision.
Mm-hmm.
Do we have final comments from our panelists?
Yeah, I mean, I agree. You can have the most efficacious drug, the most safe drug, but if you can't afford it and if you can't pay for it, there's really no point in having it. So I completely agree with you.
Yeah, and the health economic projects and plans are so important to be able to show that there is good value for money. So I think HEOR is going to continue to be, part of the future for this type of decision making.
Very well, thank you very much. Thanks, panelists. Thank you, audience, for your questions that you shared with us up front and live right now. This has helped us navigate these complex matters. It's been our pleasure to interact with you today. I hope you enjoyed. On the next slide, I'm very excited to make a communication on our coming webinar, which will be on real-world evidence and real-world data. This is happening on January the 28th, and you'll see a number of interfaces with our topic today. So a nice way to pursue the discussion with our IFAC colleagues. Thank you all. Thank you very much. Keep well in these challenging times, and speak to you soon. Thank you. Bye-bye.
Thank you.